Hi, Keith. This is Rohit. Welcome to the Big Unlock podcast. It's great to have you here.
Glad to be here. Thank you so much for the invitation.
Awesome, awesome. I always, love to visit the Bay Area. I see that you're right there in the midst of it. Uh,
hmm
it's there's so much of innovation and kind of like a vibe in the air when you visit there. It's really awesome. I was there few weeks ago for the JPM conference as well.
Yeah,
Yeah.
yeah, that is a busy couple of weeks in this
Busy
part of
couple
the
of weeks.
country.
Yeah. Fortunately, the weather was very good, so it worked out very well.
hmm
So I'm Rohit Mahajan. I'm the CEO and managing partner of Demo Consulting and Big Rio, and also host of the Big Unlock podcast. Would love to get your intro, Keith, on your background and your role, and what motivates you on a daily basis, so we can take it from there.
That sounds great. So I'm Keith Morse. I am a pediatric hospitalist, which means I'm a physician who takes care of children admitted to the hospital at Lucille Packard, which is Stanford Medicine's children's hospital. I'm
Awesome.
a clinical informaticist, which means that I study and optimize the use of technology and data systems for care delivery within a health system. Specifically within informatics, my role is medical director for enterprise AI, which means I lead the team that is working to deploy and evaluate AI and large language models within care operations in the children's hospital. I'm also an educator, so we have a clinical informatics fellowship program to which I serve as the program director. The fellowship program is a 2-year training program for physicians after they've finished their specialty training who are interested in gaining expertise in clinical informatics to prepare them for roles as CMIOs, chief AI officers, or potentially in industry. And then finally, I am a researcher, so I do research both in AI, but also I serve as the co-site PI for Stanford's participation in PEDSnet. PEDSnet is an 11-institution EHR data sharing consortium that supports large-scale investigations for improvements in pediatric health.
That's awesome. That's awesome. That's plenty to do. Must keep you
Yeah.
busy pretty much day and night. I
Yep.
can
There's
I can
no
I can
shortage of
imagine.
activity.
Yeah. So I was reading about your background, and as we were discussing previously, you did your MBA in healthcare administration, and then you chose to become a physician. So
hmm
what motivated you in that direction? And do you still practice? Do you still practice? Do you still see patients? And how does it work with the Stanford medicine, health system?
Yeah, I'm happy to. So certainly
Yeah.
still practice. So I studied econ and business as an undergrad, and then where I was at, they offered a combined MBA program. So you add on an extra year to your undergrad training, and you can start to get a sense of MBA type training courses. I
Yeah.
was doing my pre-med courses also then, and I had a couple of years between finishing the MBA and starting in med school. And actually, the job that I had was writing SaaS code for a consulting company analyzing Medicare and Medicaid data for federal and state government agencies.
Wow.
That
Yeah.
was a sort of a data scientist before the term data scientist was
Yeah,
used as commonly
exactly.
as it is now.
Yes.
And I loved it. So sort of understanding what data you have, how you can use it to answer the question, how you summarize it, how you present it back to the requester. Those are such sort of
Mhm.
core things. And so
Mhm.
I was in medical school in Philadelphia, Thomas Jefferson, and then did pediatrics residency in Phoenix, Arizona. And during both of those times, I got involved in a couple of research and operational projects in which I served as the data scientist, so writing R code. But I also got a sense of, instead of just being a data consumer as a data scientist, I was also
Mhm.
a data producer. So when you
Yeah.
start delivering care, you are the person who is standing at the bedside, talking to the
Mhm.
patient, uh, making decisions, but then you're also writing a note, ordering labs, ordering follow-up, and all
Mhm.
of that stuff is sort of the beginning of the types of data that we you eventually bill, and that
Mhm.
all of that stuff trickles into databases that get used. So in residency, I started working with our CMIO to analyze the data that was available through our EHR, really started enjoying it. And then I joined Stanford for their clinical informatics fellow as a fellow. And then I've been on faculty since then. We are fortunate here at Stanford Children's to have a forward-looking CMIO, Dr. Natalie Pagler, who
Great.
supported both myself and a small team to start building out our organization's capabilities in operational AI back in 2020. So we have sort of been working at this for the last 5 years or so.
Yes.
Obviously, when ChatGPT hit, we got a whole lot busier, but it wasn't the beginning for us. And so we are the processes we have in place now are built on sort of that early investment.
That's pretty like early on in the game. Start in 2020. So that's solid 5 years of experience on various kinds of AI implementations. So how do you think about approaching the business problem? Do you have like use cases, and what do you do with them? And
Sure.
how do you really decide where to put your energy, time, and money,
Yep.
Yeah.
And so maybe I'll answer this in sort of 3 parts. The first will be sort of talking about our process for identifying use cases, and then I can give a sort of brief overview, maybe of 2 use cases that we have that are relatively mature. So first off, I love talking about use cases. That in some ways it's this sort of like mythical concept that when you get operational AI folks together at conferences or meetings, people like sit around and whisper like, what are your use cases? What are your use cases? And the reason is that it's such an important topic because we are in essence asking, in what ways have you found that AI is valuable? Like where is the juice actually worth the squeeze? Because it's really easy to have research papers or proof of concept pilot projects that show that AI is sort of theoretically useful. But when you are the one who has to sort of make it work for an enterprise indefinitely, it's a much different problem to solve. So thinking about sort of where can AI bring value and not have it cost $50 million and not have it take 5 years to get up and running. Like those are the types of things we think about. This is actually a really hard question. And the reason is that there are 3 separate areas of expertise that have to align to get at good use cases. So the first is understanding AI technology in isolation. So what is a large language model? What is a deep neural net? What is a logistic regression? What can reasonably be expected of that technology?
Yes.
The second is what infrastructure is available at my organization to support those kind of tools. So it doesn't help you to have a sophisticated AI tool if you don't have the data available to support it, or if you don't have the compute available to support it, or if the data isn't available at the cadence that is needed for the algorithm. The other tricky part is AI infrastructure is invisible. You can't like walk into a room and like say like, oh, that's where the AI lives. It's just kind of like in the ether. So you have to have this sort of, you have to be plugged into the organization's IT system, IT sort of structure to understand what your current infrastructure is, and it changes. We're growing our infrastructure. We're making investments. It's different now than it was 2 years ago, and 5 years from now, it's going to be very different. So sort of understanding where we are in the infrastructure is point 2. Point 3 is by far the most important and by far the hardest, and that is workflow expertise. So AI does not solve nebulous, non-specific problems. In theory, it has to solve a specific problem for a specific human in a specific job, in a specific part of their job. We sort of summarize all of that by saying like kind of workflow, like where in a person's workflow can AI potentially be useful? The problem is that healthcare is a diverse, complicated entity. My health system is different than the health system down the street, different than in Cincinnati or Texas. And there are so many different workflows, even within my organization, that there's no one person who sort of understands all of them. So our process for how we learn about these workflows, and this is actually something that my team spends a lot of time doing, is talking to people within our organization to help get them to tell us what are problems in your organization and how could AI potentially help?
Yes.
So you would think that's easy. Like you would think I can just like go talk to somebody and we can figure this out. It turns out, surprise, surprise, to be shockingly difficult. And the reason is this. So if you imagine a sort of a standard organizational hierarchy, like you have your sort of director, supervisor, executive oversight, you have your manager, and then you have the sort of boots on the ground folks. This could be rev cycle, supply chain, sanitation, like anything. Usually when you talk to the more senior folks, they are very excited about the types of things AI can provide. Speed, efficiency, safety, uniformity. And so they're sort of on board. But being a manager is different than being a boots on the ground employee. And so the leadership often don't understand what happens on a day-to-day basis in their teams. And that's not a dig on leadership. It is a fundamentally different job, and people who oversee big teams, like it's too much to know. So you can't look to leadership to tell you where the problems are. Also, most likely leadership is not the one who's going to have their job supported by AI. It's going to be somebody who's doing more boots on the ground. So you have to talk to the folks who are potentially going to have their workflow impacted by AI in order to understand exactly what is your workflow and exactly where in this workflow would AI potentially be helpful. So usually the way we do this is you sort of start at the top and work down. You sort of get buy-in from leadership, and then usually you get passed on to sort of middle manager, and then that person says, here are 3 or 4 ideas that are potentially worth pursuing. Then we meet with each one of the teams of those 3 or 4 ideas, and we say, tell me specifically, like, what it is you do, what data do you look at, what is the problem that you can solve, and how potentially could AI support that? Our hit rate of those meetings is relatively low. Most problems are not solved by sophisticated AI. There's usually either
there could be other ways to solve those, right?
Exactly. So our biggest takeaway is usually like directing teams to our existing data and reporting tools that are much simpler and can solve the problem just as well as some sophisticated AI tool. But out of that process, we end up with sort of good use cases, and that's sort of going to inform a couple of the things I have to talk about. But I guess the main takeaway here, and so the biggest point is that nobody outside your organization can credibly provide a use case that is guaranteed to work for you, because they may know about AI in general, but they don't know about your AI infrastructure, and they don't know about your specific use case, or excuse me, your specific workflows. Like I don't even know most of my specific workflows in my organization. So how would a third party or a hospital in Minneapolis know that? So there is a sort of long-term role for identifying the use cases that you have within your organization, because they aren't transferable from other institutions.
Very good observation.
One area in which this is kind of breaking down, and there's sort of exceptions here, is when AI is embedded within your electronic health record. So for example, we have a couple of tools. So our electronic health record is Epic. We are using a couple of tools that they provide for us. One of the big ones is around using large language models to draft messages or draft responses to patient messages. This is a use case that is gaining traction nationally. There's lots of hospitals that are using this. The reason that it is relatively, we can relatively reliably use this use case, even though it's sort of provided by Epic, is all 3 of those areas that I mentioned, Epic controls, or Epic sort of can provide or manage. So for example, Epic understands that drafting patient messages is well within the capabilities of a large language model. So that's point 1. Point 2 is, for the infrastructure, all of the infrastructure that you need in order to use this message drafting use cases exists within Epic. So I don't have to bring any additional resources to make it happen. Epic provides it all. So the infrastructure issue isn't there. And 3, the workflow for responding to patient messages exists entirely within Epic. And so they have a pretty good understanding of what our message workflow is because we use theirs. So
Right.
there isn't the same variability of workflow that perhaps would be elsewhere. Now, for example, if this process or if the workflow here required me to read something in Epic, then go to a machine and do something else, talk to a patient, do something else. Basically, I was away from the computer. It becomes much harder for Epic to understand the totality of that workflow,
Right.
and we sort of introduce some variability. But with responding to a basic message, it's all on your computer. It's all within Epic, so
Yeah.
it's sort of visible. So this is where we start to see use cases that are broadly transferable have to sort of have all of those pieces contained in them in order to be applicable.
Right. Right. So Keith, talk to us about and share with the audience, please, what has been your experience with some of the large language models and where you have been successful in implementing some of those.
Yep. So we have a couple. We tend to publish most of the work that we do. So a lot of this is available in the literature. One of our big use cases is around using machine learning to help identify confidential content in teen notes. So there are laws in the state of California and most other states that protect teens for seeking care for certain types of sensitive issues. So mental health, sexual health, substance use. In the state of California, there are explicit laws that prohibit providers of teens, so people who take care of the adolescents, from telling the parent of the teen that they are receiving this care. And the reason for that is that there's lots of good evidence that teens are more likely to seek care for these types of things if they can be promised that it's not going to get back to their parents.
I see. Yes.
The problem with that is that there are also federal rules that require that we as a health system make patient records available to parents and their or teens and their parents. So 21st Century Cures Act requires that health information is available without undue effort. Basically means that parents have to be able to get or view their records usually through a patient portal. So we're within the health system for anybody who takes care of adolescents is in this bind where the federal government says you have to share all of the patient's notes with the patient and their parents, but there's a state law that says you can't share the portions that are involved with these three sensitive topics. So we get around that by we have what we call a confidential note type. So providers can document this type of information in a confidential note type. We can prevent that note from being shared to the parents, and that works great. The problem is that not everybody uses the confidential note type to the extent that we wish they did. So we know that there is confidential information in these notes that we are theoretically would be sharing with the parents and the families.
Yes.
So this is a great application for large language models because this is essentially processing large volumes of text to identify certain definable concepts. So this is one of the projects we worked on before large language models came out. So we developed a bespoke large language model, or excuse me, a bespoke NLP model to help identify these concepts, and then we have replicated that analysis using large language models. And the way that we use it now is that we use it as a retrospective audit and feedback mechanism. So we process our sort of different the notes of different divisions, and then we can see sort of who in the division is sort of documenting in a way that's potentially problematic, and then we can bring that back to the individual and also the leadership and sort of say, hey, just FYI, like we noticed that your notes contain a lot of information that would run afoul of the California state privacy laws. We can then help providers improve their documentation. Often what it is there's some sort of smart phrase or automatically pulling in patient information that's considered confidential. So we just sort of edit or help update somebody's note template, and that the problem goes away. So it's those types of sort of nudges that we think are helpful and really get at what we want, which is to be able to share patient information with the teens and their parents. We want this stuff to get out. We just need to do it in a way that is thoughtful and responsible.
That's
Um,
that's amazing. And how about any other use cases
yeah, so
in hospital operations?
sure. So we have one that this is not pediatric specific, and it's
Mm,
around quality tracking and quality metrics. This is work
mm,
that we haven't published quite on yet, but so health systems, as you well know, are on the hook to report on various quality metrics.
mm,
One of the quality metrics is around surgical site infections. So identifying what percentage of patients have a surgery, an infection at the site of surgery within 30 or 90 days after the procedure. That's a marker of surgical quality, infection control, lots of really important things for health systems. We have teams within our hospital whose job it is to both track these metrics and then identify ways that we can intervene, identify bundles that we can introduce to help improve these metrics. But there is a sort of core function of tracking and identifying whether a surgical site infection occurred. The way that works is that there is a team of folks who essentially read the patient's chart after a procedure to identify whether or not a surgical site infection occurred. So, reading patient notes about how the patient came back to the ER with what looks like a surgical site infection, where they were prescribed antibiotics by their PCP, those types of things would flag as there being a surgical site infection. Now, it's a ton of work to have a human read every chart following every surgery for 30 to 90 days.
Yeah.
So what we developed was a process by which a large language model is used to review the notes in that relevant time window. And we ask the model a relatively straightforward question. So the prompt is relatively simple. And it's basically, for a given note, do you think this note contains evidence of a surgical site infection? Very simply that. Do you think this note contains evidence of a surgical site infection? And of course, we do few shot where we provide a couple of examples and help it understand, what are some keywords. And then we do that for every single note the patient has in that post-surgical time window. And we come up with a score of basically what percentage of the notes does the large language model think has a surgical site infection. And we see that when we run this on our historical data, we see that it's the large language model thinks that somewhere between 0 and like 60% of the notes refer to a surgical site infection. What we can do then is we can draw a threshold, say 5%. And what we do is we would then say the human reviews everything above 5%. So we still need a human to understand sort of the nuances of what counts as a surgical site infection, reading the lab results, reading the imaging results. We need a human to identify the true positives, but there are many true negatives. So somebody who never has an infection, like does great, doesn't come back to the health system, like that probably aren't worth a person's time to review those notes. And if we can identify the true negatives, the person can, the reviewer can spend more time on the sort of on the true positive. What's fun about this is that the numbers are exceptional. So if we at a threshold, for our sort of preliminary data, this is looking at 2023 and 2024. For our preliminary data, if we set this threshold at 5%, the reviewer would be reviewing 70 to 80% fewer cases.
Wow.
70 to 80% fewer cases, and we would miss, so this is not perfect, we would miss somewhere between like 2 and 5 cases. So it's not perfect, but we are sort of nudging toward this world where we can spend our time reviewing the cases that are problematic and positive, and less time sort of filtering through the vast majority of surgeries that don't have an infection, don't have an issue, and move those to the back of the queue. So those are the types of things where we aren't replacing a person. Like this is we still need a person to be involved, but we are helping that person focus their energies on the cases where their expertise and their interpretation of what is actually happening is maximized.
Yes, that's great to know. And as we all know, Keith, Gen AI and LLMs are becoming all pervasive. You have a large workforce at your health system, people at various skills level. and now they have to either use some of these systems that are going to be deployed, or they're already participating in what you described as the use case process. So if there's more appreciation of Gen AI and LLMs and the AI, they would be in a better position to do their job and kind of embrace it. So how do you go about, learning and development and upskilling your workforce? What are your thoughts about that?
Yeah, that's a great question, and I think is foremost on the minds of health system leaders who are hoping to use AI in any meaningful way. And the reason it's so important is that it is totally unrealistic to expect somebody to use a tool that they are unfamiliar with, particularly when that tool is something that is sort of amorphous and multifaceted as a large language model. If you think about it, if we sort of use the analogy as large language models sort of distilled down are basically like office productivity tools. And you think about other office productivity tools that we use regularly, like think Microsoft Excel. Like Microsoft Excel has been around for 40 years. Like I used it for, middle school projects. My mom used it when she was, working at a bank in the 80s. So most people, by the time they enter a workforce, have experience with using Excel, and so it's not unreasonable to have that be a requirement of the job, or when Excel gets sort of augmented in new ways that people are able to sort of jump on it, and it's relatively straightforward. We have none of that with large language models. So it is expecting people to use these things without a ton of training is really unfair and unrealistic, and that applies sort of up and down the organization chain. And what I mean by that is like leaders, just because you're a sort of executive VP, you have exactly the same number of 2.5 years of being sort of aware of these large language models. And so it's not, whereas historically people would be able to turn to coworkers or maybe get extra training, that doesn't exist because it is just so new throughout the organization. So you make an excellent point about sort of needing to upskill our workforce and attaching an experiential component to that training, because sometimes we hear about sort of folks who have like online modules where they expect their workforce to do. I don't think this is the sort of thing where watching some videos is going to really get you the insight you need into understanding how these tools work. Experience is king here. Like we have to figure out how sort of rank and file employees of our organization and every organization can get access to these tools. The reason it's a trickier in healthcare is it's one thing to tell somebody, hey, go play around with ChatGPT and see what you learn. But we don't want people to use ChatGPT for coming up with recipes or coming up with poems in Pirate. Like we want people to use large language models for their job because we suspect that there are major productivity benefits that can come out of this. But you obviously, in a health system, most people's jobs involve PHI, patient health information. You can't put PHI into public models. So we need to make things available. We need to make a PHI-compliant large language model available to our employees. So we at Stanford Children's and our adult hospital have made a large language model that is PHI compliant available to our entire workforce. We've had it available for about a year now, and we are, so we call it, so our IT department is Digital Information Solutions, Digi IS. So our chatbot, we call it Ask Digi. But the idea here is that we want to encourage people to start experimenting with an appropriately provisioned large language model to figure out how it can make their life better. Like, again, going back to this sort of workflow insight, like I have no idea how somebody in a rev cycle role could use large language models to make their life better. Most folks in the rev cycle role don't know that yet. We're going to figure it out in a couple of years, but like we have to kind of let people experiment to learn that. So we have sort of two broad, or I guess three broad approaches for training. One is the sort of online modules and training. We have a couple of training tools, both generally about what large language models are, and then Ask Digi and the local tools that we have available. Our second is prompt engineering workshops. So we have two of our clinical informatics fellows who have developed a 2-hour hands-on in-person workshop for how do you develop prompts and how do you know that your prompts are sort of doing what you want. Prompting is a totally, engaging with a large language model through a prompt is a totally new skill. And so starting to get people to understand like what is required in a prompt, lowering the sort of fear factor, like giving people the confidence to say, you know, you don't have to be a computer scientist to prompt this thing. It's relatively accessible. It's totally accessible. But that comes through these sort of education sessions. And then the third is having, and you kind of hinted at this earlier, having a local champion or a local expert who gets involved in a pilot project and then understands a little bit about how the large language model works, and then can bring that insight back to the rest of their teams. So for example, our work with the surgical site infections, we are working with the folks in infection prevention and control, and they are seeing the sort of ways that large language models are helpful and are not helpful. They're sort of with us as we are learning. Those folks are now going to be the experts in their team for how these tools can be used. So and then hopefully that goes on to sort of propagate into more training. But engaging folks in these pilot use cases is helpful, not only because you learn about the use case, but you train the person in that area that hopefully has some ripple effects.
That's great to know that there's so many initiatives to upskill and for learning and development in the organization. One other topic that I thought I would touch upon was we talked about it a little, was the PEDSnet. You mentioned it early on in the conversation today. Would love for you to share with the audience on how this helps in terms of interoperability and data sharing and any how it might kind of feed into the AI aspect of things as well.
Definitely would happy to. So just for sort of a quick background, PEDSnet is as I mentioned, pediatric EHR data sharing consortium that has been around since 2014, 2015. It's primarily run out of CHOP, so Children's Hospital of Philadelphia. They are the coordinating center. We have a relationship with them as all members of the network do, and we send them a harmonized version of our EHR data 4 times a year. The harmonization is based on an OMOP model. So the Odyssey community is a sort of open source EHR standardization sort of initiative, and PEDSnet has adopted their common data model as the bedrock of what we use. We have some minor modifications that are specific for pediatrics and specific for care in the US, but we are able to share data to a central location, and then able to do studies that get at a volume of patients that is unmatched elsewhere. So about 15% of the children in this country are represented in our PEDSnet database. So it's a chance for us to do large scale studies at a fraction of the cost that it would otherwise take to develop these types of tools.
Great.
As we sort of get into the world of large language models, it's not too hard to envision a future where we are able to have a large language model help us process unstructured information from these different sites to extract relevant things of interest from notes, and do large scale studies that look at notes and look at unstructured data. That's not here yet, but is sort of in the near future, and so it's really exciting to think about the potentials.
That's awesome. Talking about near-term future and potential, if you were to look in the crystal ball, Keith, what are some of the things that you see coming down the pike? Agentic AI, people are talking about virtual nursing, ambient listening. There's so much going on. What do you think is kind of some of the big things coming our way?
Yeah, definitely. So we are sort of rolling out a pilot of ambient listening and have a sort of, I think, a similar queue as many other organizations for things that we're going to be adopting in the near future. I think from taking a slightly step back, from a sort of regulatory and oversight perspective, it's important to sort of remember that type of those types of issues aren't going away, regardless of how excited we are about the technology. So if you sort of think about any investment in technology requires an understanding of the upsides and the downsides. We, I think, are a little over-indexed right now in terms of what are the upsides of this technology. We're very excited. We're very excited about what it can do now, what it can do in 5 years. We're starting to see some efficiency gains. The feedback, particularly around DAX and other ambient listening, is generally very positive. We are less concrete about the downsides. And what I mean by that is there's lots of talk about sort of potential issues that come with AI. In the past, we have relied on federal or state agencies to provide some oversight to make sure that those downsides aren't present, or sort of they're appropriately mitigated, appropriately recognized. AI, and particularly large language models, is proving very difficult to regulate just because it's such an amorphous entity. So I think it is unrealistic that we're going to see a robust regulatory system in the near future. So what that means is that the burden for making sure this stuff works is falling on the provider. And that's great until it's not. And what I mean by that is so the burden is on the providers to use these things appropriately. At some point, we're going to see a lawsuit of somebody who claims that they were harmed because of the tool, because of a large language model's involvement in their care. Once that happens, we are going to get a very concrete piece of evidence of the types of downside that are inherent in using these tools. We haven't got there yet. Right now, the downsides are so amorphous, they're easy to sort of ignore. Once there is a price tag attached to the cost of mistakes, then things become different. If that price tag of a mistake is enormous, the overall value of these things could change substantially, because we know that we are, particularly early on, we are sort of potentially introducing risks and mistakes with the use of these tools. So even if the output of a large language model is 99% accurate, and you have a human in the loop who is reviewing it, and their review is 99% accurate, there is still errors that are present. So part of the reason I bring that up is that for an organ, we take it very seriously here at Stanford that we are ultimately responsible for the use of these tools, how they impact our providers, and how they impact our patients. Nobody is going to take that responsibility from us, and that is appropriate. But we are sort of building systems. We are building processes with that sort of worst case scenario in mind, in order to prevent it from happening.
And that is very prudent and cautious. So with that, I think, Keith, this is a great session. Any closing remarks? Great interaction. And
thank you so much for providing this opportunity. It's exciting to be able to talk about the work that we're able to do here. I think there's lots to talk about pediatric implications. So maybe we'll find some time in the future to talk again.
Absolutely. Looking forward to that. I'll stop recording now.